Still loading, one moment. All right, take it away, Dr. Sutton.
All right, well, welcome everyone. Very excited to be hosting this webinar this evening on interventional cardiology plus family plus life. Can these coexist in harmony? I am joined today by a really outstanding panel and a couple of speakers who are all interventional cardiologists. And I'm very excited. I did understand that we had a very strong showing in terms of registration for this webinar today with over, I think, 75 registrants, just demonstrating the interest in this topic area. So my name is Nadia Sutton. I'm an interventional cardiologist at Vanderbilt University Medical Center in Nashville. I am joined today by the two speakers we have are Dr. Jennifer Reimer, who is at Duke, who will be speaking on considerations for radiation and other occupational hazards during pregnancy. What do we know about the risks? And then followed by Dr. Marcella Calfin-Press, who is at UCLA, who will speak on building your family as an interventional cardiologist. And then we will have opportunity to hear from several wonderful panelists who are leaders in our field of interventional cardiology. Dr. Holly Bowser-Heaton, who is representing the pediatric interventional cardiology field and is practicing at Emory. Dr. Molly Zerlup, who is at the Baylor Scott and White, the Heart Hospital in Plano, Texas, who will be joining us today. And then Dr. Michelle Volz, who is currently practicing at Northside Hospital Heart Institute in Atlanta. So a very wide representation in terms of geography and backgrounds and interests. So I will actually ask if each of the panelists, and I know Marcy had to pre-record her case or her presentation because she is in the middle of a complex case. And so I would like to just give each of the panelists an opportunity to just tell us a little bit about yourself, maybe about your, your clinical interests, any other roles that you have at your institution, and maybe a little bit about you personally. That would be great. So Michelle, you're the first that I see on my screen. Maybe you can start.
So I'm Michelle Volz. I am an interventional cardiologist. I've been in practice about 20 years now, dating myself a little bit, but I have interest in complex coronary intervention, cardiogenic shock, pulmonary embolism, and then also my side job, as it were, is cardioobstetrics. So I have the privilege of working with expectant moms with heart conditions or heart concerns and helping get them safely through delivery. Most of the time, that's some office visits and some reassurance. But obviously, the other end of that is, ECMO and crashing things and other excitement. I have 6 kids. I'm a single mom. I actually live with my sister and her 4. So it's me, my sister, the 10 kiddos, and our 94-year-old grandmother. So we have a very active household, and I do a lot of balancing, a lot of juggling. And so this is a really pretty appropriate topic for me. And so I appreciate the ability to be here today. Thank you.
Awesome. All right, Molly, do you mind introducing yourself?
Yeah, hi, Molly Zerlup. I'm an interventionalist as well, obviously, and a structuralist. I run our cardiology fellowship program, and I'm the associate medical director of education and research, which oversees all of the cardiology subspecialties and all the research at the Heart Hospital, as well as the regional structural director for our north part of our Heart Hospital enterprise. I like to say I'm 100% clinical and 100% administrative. I wear 2 hats every day with both those. We just merged with another heart hospital, acquired them, and so we are a big we will end up having 10 heart hospitals and multiple MSAs that we're supporting. So I am interested in high-risk coronaries is what I do, and obviously the structural, all of the structural procedures. I too am a single mom. I have two grown daughters and two grown stepsons and 7 small grandchildren from the 2 stepsons. So I'm very busy in my outside world. Oh, and plus I have horses. That's my big thing as I ride to stay sane. So.
Awesome. All right, Jen, can you introduce yourself?
Yeah, hi everyone. Glad to see everybody here. So I'm an interventional cardiologist at Duke. I do peripheral vascular interventions too. I have a big interest in peripheral vascular disease. I am starting as the program director for interventional cardiology at Duke, so I'll be taking on that role starting in July. And I have a big clinical trial interest, so do a lot of work at the Duke Clinical Research Institute for several randomized clinical trials in ACS and PAD, and then as well as some registries. So lots of research interest. I have 2 children. I have a 7-year-old and an 11-year-old, and a small dog who's just as complex as the children sometimes. But so they keep me busy, and they are kind of my hobby. I'll be honest. I haven't found the outlet to keep me sane yet. So. But a lot of fun in both my job and with my family. So yeah, it's a little bit about me.
All right, awesome. Hi, Holly. Looks like you're able to join us. Dr. Holly Bowser-Heaton is joining us from Emory, and we're just doing a little sort of self-introduction about your interests, a little bit about you personally, any other hats you wear in your institution.
Yeah, so nice to see everybody, and of course, running back and forth from the cath lab as usual. So I'm rushing into this seat, but happy to be here. So currently, I am at Children's Healthcare of Atlanta. I'm a congenital interventional cardiologist, but happy to report that I just took a chief position at the University of Texas and will be the executive director of the Children's Heart Institute there. So pretty awesome to make that transition in August. I'm a mom of 4. I too am a single mom. I hear that theme, and I know a few ladies on here are. And probably the thing that I love the most, and like Molly, find my sanity in other things, is the gym. And if you guys ever want a workout partner on a conference day, grab me in the morning. I'm happy to do that with you. My interests clinically are in complex pulmonary artery disease, and I love the crazier the better. It's just been a really neat experience to help the kids that really don't have a whole lot of options. And then I will be taking over as your WIN chair this year, and super excited to do so along with Michelle. So nice to see you guys.
Right, awesome. So I think with that, we can lead into our first presentation, which Jen will be giving. So Jen, you want to take it away?
Give me 1 second. I'm going to be that person that's takes a few more minutes on some of these things. Can you all see my screen okay? Perfect. And is my volume okay as well? Okay, perfect. All right, everyone. Well, so I've already done an introduction, but I'm really excited to talk about considerations around occupational hazards and radiation exposure in pregnancy. But I don't know that we should honestly just be thinking about it in terms of pregnancy, but really your whole career as an interventional cardiologist, including trainees, because really, I think the SCAI initiatives recently at annual sessions really sort of opened my eyes to how much more I should be thinking about my everyday occupational hazards if I want to keep doing this for more decades. So I'm going to make it broad. There is going to be some focus on pregnancy, but I do want to keep it broad because I think as women, we should be thinking about all of the risk out there for us inside and outside of pregnancy. Just quickly, my disclosures, none of which are pertinent to this. I want to show this picture. So this is my daughter. She just turned 7 today. I was pregnant with her when I was finishing up my general cardiology fellowship. I was in and out of the cath lab a lot. I remember feeling really stressed about what kind of exposures I could be potentially bringing to her and what that would mean for my pregnancy, and just being really nervous about it. And now we're celebrating. This is her dance recital from this past weekend. We're celebrating a really happy, healthy 7-year-old today. And so I just bring that into the forefront of, I think we can all make really careful, safe decisions and be thoughtful about our pregnancies and in general, our life in the cath lab. And you can have successful pregnancies if you follow a lot of what I'm about to talk about. So family planning, I want to talk about a little bit about this because I think Marcy will discuss this briefly in her next talk, but I just love this paper. It was published in JACC in 2017, and it really talks about the lifespan of a woman from sort of thinking preconception to early parenthood and then to radiation risk subsequently throughout their career. And it's just a great overview. And I think it brings to the forefront a lot of the reasons why sometimes women aren't choosing interventional cardiology as a subspecialty. There's a lot, I remember feeling concerned about, well, what happens if I have some sort of gestational issue as a result of going into this field? And what kind of regrets will I have? And what can I do to be safe? But also being worried about early disclosure. And so this article talks about a lot of the considerations about you may not want to disclose early on, but about the pregnancy, you want to remain safe. And so what are some things you can think about? Women, obviously, I think there's been data that I'll show. Women feel a pressure to take less maternity leave when they do have a successful pregnancy. And sometimes that can lead to postpartum issues like postpartum depression, issues with breastfeeding. Women may come back to a busy cath lab and want to stay successful and do high volume of cases. And there may be pressure where they can't stop and breastfeed. And so maybe there's issues with supply. So all of those things are considerations I think we should be thinking about. And when I think about occupational hazards, I don't just think about it from the sense of lead effects on your cervical or your L spine, or radiation or your eyes, but also occupational hazards from how it sort of can impact your life as a whole. So occupational dose limits, let's go through just some brief basics that I think we should all know. So dose limits for your whole body, the maximum dose of 50 millisieverts per year. And so both the ACC and SCAI have really nice materials online that you can quick look up references about dose limits that are readily available. So keep those in mind. Your islands and your skin and your extremities are listed here as well. Importantly, the fetus is about a half or 0.5 millisieverts per month or 5 over the course of the entire pregnancy. So those are some basic numbers to know. But then when you think about it sort of as a whole, the known threshold for fetal injury is about 100 millisieverts. I told you for the entire gestation period, it's about 5. What we experience just walking around the world, down the sidewalks in our everyday life on an annual basis is that we'll have about an exposure of about 3 millisieverts a year. 0.3 is what is expected for the under lead dose to the working pregnant interventionalist over the entire gestation, and 0.9 is how much the fetus of a working pregnant interventionalist probably receives over the entire gestation period. And I think what's important to know is when I was looking into all these numbers back in the day, I remember thinking, oh, so as long as I do what I'm supposed to, it's likely well under what could cause potential harm to my fetus or to me. But general recommendations, you want to obtain a fetal radiation dose badge. You want to make sure that you have protective garments that provide at least 0.5 millimeter lead equivalency through the entire pregnancy. And there's some recommendations out there that earlier on in the pregnancy, you might want to consider 1 millimeter lead equivalency earlier on. At the same time, you want to minimize the weight of the protective garments because as you become more and more pregnant, it's obviously very hard to hold additional weight. So you want to also make sure that the garment is fitting correctly throughout as your body changes. And so one of the things to potentially think about, and I've navigated this certainly with fellows and some of our techs who didn't want to necessarily disclose that they were pregnant, but wanted to make sure they're safe, is making sure you know who you can talk about in radiation safety or physics at your institution, knowing that you can wear a second layer of protective skirt during that period of time if you want to be extra cautious earlier on. And don't want to disclose. But obviously, I think being that advocate for women in the cath lab, I found really fulfilling if they don't want to necessarily talk to their managers or to more senior administrative individuals. And I think this is just some other general thresholds to keep in mind before implantation for fetal periods, 8 to 15 weeks, 16 to 25 weeks. Now, this is in terms of milligray, but again, very high numbers, I think, to potentially cause some of the issues that we're concerned about, like congenital anomalies, certainly death of the embryo, intellectual deficits, all of those things. So I think safe practices, and I'll talk about some of the other, obviously there's newer technologies that are available in some cath labs and not others. But that may make it even a safer environment for the pregnant interventional cardiologist. Now, but there's certain considerations that we should think about. Radiation in women interventional cardiologists. So there's been several surveys. I know SCAI has done one that I'll talk about. Certainly ACC has as well. Survey of cardiologists asking, why didn't they pursue interventional cardiology? And women were significantly more likely to respond with the fact that they had radiation concerns. And this was notable, particularly among women less than 40 years of age. Like I said, younger cardiologists were more likely to respond that radiation exposure was a deterrent to entering the field. And over a third of women reported not knowing if their department even had a policy regarding radiation exposure and pregnancy. And so I think it's really institutionally, there should just be an open knowledge about who to contact, who you can talk about in a discreet manner if you don't want to necessarily disclose it to your whole cath lab. But I don't think that that's often at times in place, and so you may feel uncomfortable. And a lot of these practices, I think, are probably deterring our young women from wanting to go into our field. Length of maternity leave. So I found this fascinating because I will say both of my leaves were less than 6 weeks. One was less than 4 weeks because I remember feeling like I wouldn't be a good trainee if I took so much time off and that I shouldn't do that. And I think that that's what we see in this. So this is from this survey looking at length of maternity leave. And you can see that 15% take less than a month. These are trainees and cardiologists, so attending cardiologists and trainees. 30% 4 to 8 weeks, 30% 8 to 12 weeks. The vast minority are taking more than 3 months. And certainly if you go to our European countries, to our interventionalists in other countries, sort of Canada and European neighbors, they are taking much longer maternity leaves than we are here in the US. And then again, I think there's a pressure. So the second panel on the right, the question was, did I feel pressured not to take as much leave as I had available to me? You can see for trainees, significantly higher than attendings. And I think that makes sense. Many times you're getting close to sort of a terminal point in your training. You want a job, you want potentially a job at the institution you're training at. And so you want to make a good impression. And so there's a lot of potential issues there. And again, just age, down here on this left-hand panel on the bottom, more likely to say that you were having stress and feeling a pressure to come back from maternity leave earlier than what you were allotted for younger women. So I think all of this is not surprising to us, but certainly are ongoing trends within our subspecialty. So then some of the considerations I wanted for the panel, hopefully there will be time to discuss some of these. Timing of disclosure of pregnancy and impact on radiation safety. You know, from your experiences, what would you say in terms of how to disclose, when to disclose, what are considerations, and what advice would you give to young women who are pregnant or considering becoming pregnant? And then after maternity leave, the other needs when returning to work, how do you best navigate that? So how do you have come back from maternity leave and now all of a sudden you've got to say, well, I need a certain amount of time to pump, or I need to do this X, Y, or Z. How do you navigate those conversations and what do they look like? So I bet a lot of people have those questions. So those are just questions I'll pose. Maybe think about those while I finish out some of the other risk here. So cataracts, you know, we had a colleague at another institution recently that had to stop doing cases because cataracts had become such an issue for them. So it's a big deal. And I oftentimes see some of our fellows or other colleagues go in without their lead glasses just for a quick case, or it's, you know, I don't have them with me, so I'm going to go ahead and just go in. So posterior subscapular cataracts seen in 33% of interventional cardiologists. This is a relative risk ratio 3 times higher than unexposed controls. And this can really limit your career. It can shorten your career and certainly can make your older years more complex too. Wearing lead glasses confers less than 75% of the time conferred a 6-fold increase in your risk of developing cataracts. So again, I know that this is supposed to be looking around the pregnant interventional cardiologist, but these are things that we also have to think about, I think, for all of us. Certainly brain and neck cancers. I think many of us know that there's an increased risk of neck and brain cancers. For ICs, 55% are unfortunately GBMs, so the worst category of brain cancer. 85% are obviously left-sided tumors, just based on where we're standing. And really, there's a median latency period from start of practice to diagnosis of around 22 years. So I think making sure we're aware of that, thinking about radiation caps and other safety mechanisms to help avoid these. And then, you know, I like to bring this up. I'm always a little surprised at this, and I thought this was great that SCAI brought this up this year in a couple of the talks. And we oftentimes think of the risk for the interventionalists, but many interventionalists who are doing procedures with interventional echocardiographers, the risk for those imagers is actually higher. And so this was a nice publication from 2022, just looking at the risk, the personal dose equivalent per case of structural heart procedures, significantly higher for the interventional echocardiographer. You can see here for several structural heart procedures. So important for us to be educated, but also to make sure that these individuals are educated as well. And so mitigating risk. And I'd be interested to hear some of the strategies your institution have put into place for mitigating risk. There's obviously basic things that we can do on an everyday basis, from collimating, from keeping the detector close to the patient, making sure your shield is in place. But there's a lot of technologies out there available, not available in all cath labs, but I think would be great for the panel to sort of highlight what's available at your institution. That's potentially making you all safer, making it a safer environment from not only a radiation exposure, but also from an occupational sort of not having to wear lead, not having to wear as heavy lead, and having less pressure on your back. Just show a couple of pictures of those, but certainly I'd love to leave it to the panel to describe. I think it would be nice to know what everybody has available. Again, not all cath labs have these technologies available. From a musculoskeletal pain perspective, I think we hear quite frequently, it's not uncommon for an older colleague of mine to be going out for back surgery or knee issues. And I think oftentimes, how many of us see people staying in lead at the end of the case to finish up something, not really thinking about that extra time in lead and what that's doing to your back. This was a Mayo survey of employees working in spaces with radiation exposure, primarily their cath lab. And really, and I mean, this is not surprising, those that were most likely to have musculoskeletal pain or to have had surgery were those that just had an increased dose exposure to the cath lab, to lead over a period of time, or typically were your older individuals and people that have been in their current profession more than 15 years. The orthopedic risk, very much related to your annual case volume. I thought this was from the SCAI survey that was published in CCI in 2015. And if you're doing 900 or more procedures in a year, you're at the highest risk for all orthopedic issues from the C-spine, T, and L-spine. Dramatically decreases as your annual case volume decreases. And I think that's not surprising. It's just a surrogate marker for being in lead more frequently. But then there's other issues that are outlined, other illnesses, injuries that are shown in this bar graph to the left. And then just shows, if you map it out, it's really an exponential rise as your annual case volume rises. Your risk of cervical spine, hip, knee, or ankle problems, lumbar spine problems. And certainly, I think when you're thinking and trying to take this back to the pregnant interventional cardiologist, being on your feet all day, you may not have a lot of time to drink adequate hydration. All of that can put you and the health of the fetus at risk as well by just carrying that extra weight. So in conclusions here, I think brought up a couple of concepts that I hope are known to most, but I think maybe a sort of a springboard for panel discussion. Orthopedic and radiation exposure, I think, has really important risk for interventional cardiologists. And when we're early on in our career, we think we're invincible, that none of these things will ever happen. And then all of a sudden, the back pain sort of starts to catch up with you. It's really dependent on your years of exposure and volume. Concerns for radiation exposure may be a deterrent to female trainees because of pregnancy exposures. It's important to recognize that other members of the team, potentially other pregnant members of the team, and also have radiation exposure and MSK risk, and it's important to make sure they're educated. And then risk overall can be mitigated by proper equipment, but I think there's also a need to really lobby our cath labs and our administration to help get some of the new available equipment into our labs that can help us reduce a lot of these exposures. So I'll stop there. I think I took a little bit too much time. Sorry about that.
No, that was awesome, Jennifer. Thank you so much. And I just am very impressed at your ability to give such an excellent talk, being jet lagged and just returning from Paris earlier today. Superwoman. So that was, there's quite a few things I think we could touch on based off of your talk. And I know you kind of gave us a springboard for a couple of different discussion points, but I think what we'll do, I'm going to go through a couple of sort of topics, and then I think we have enough time for discussion here before moving on to Marcy's talk. So I guess first, one question I have for you all is, when you were considering the field of interventional cardiology, were there any things that you were told about being, especially being a woman in the cath lab or the field of interventional cardiology in general, potentially not even related to being a woman, that you might have been deterred by, or that somebody was maybe attempting to deter you from the field? And does that advice that you received align with your experience, or was it, does it not align with what your experience was? So maybe Molly, I don't know if you could maybe comment first, and then we'll kind of go through the panelists and everybody can answer that question.
Yeah, when I was, it wasn't really with interventional cardiology that I was was told it would be tough. It was just cardiology in general. I remember I was in the military and I said I was going to apply for cardiology, and one of the program directors, not from the military, but from a civilian, was like, that's going to be really hard for you. You have family, you have young kids, because at that time I had small kids, so you may want to consider that when you're thinking about it, like really trying to determine. Of course, I did the opposite and was like, heck no, of course I can do this. What do you think I am? And went. And I actually went to a program that was very family friendly. So that was number one. I really only had one place I could go, just because of my husband at the time and whatnot. But turned out it was very a family friendly program. So that was number one. When people came to me, women especially, asking, I said, you may want to look and make sure that it's a family friendly program, that they're not going to get upset with you for having a family. And then the same thing when I looked for interventional, I was looking at places that wouldn't, that was also family friendly. And I mean, really, that was why I ended up at Cindy Grimes' program in Beaumont, because Cindy is Cindy. So, so for me, I kind of beforehand did some really looking to make sure that didn't happen. You know what I'm saying? To make sure I wouldn't get discouraged from people, and make sure it was a place that was that wouldn't discourage me.
Yeah, that's really good advice. So kind of like finding a training program that aligns with you personally. But not every program is the same. Yeah,
and you can do that by asking people. I mean, you really just, you ask the fellows when you're going around, really saying, you don't have to ask them directly, do they treat you well? Could you have kids? But, there's certain things that you can kind of get at to see if they are like that. Because unfortunately, even though we talk about this all the time, there are still some places that are just not, I mean, they just don't get it.
That's good advice. Jen, what about you? In your experience, I know you've been at Duke for a long time, so you can feel free to tell us whatever you feel.
Yeah, no, I think, when I remember, I think Duke has evolved a lot, which has been great. And I think we now have more women interventionalists in the cath lab now. But certainly when I joined faculty, I was the first interventionalist female that they had ever hired. And so among 20 other men. So I remember feeling like, gosh, I'm glad I went ahead and had my children early on, and and potentially had even thought about having a third, but just didn't know if it would be the space that would necessarily be conducive to doing it. Just from a worrying about coming back and having, adequate leave, and then obviously wearing lead full time early on with a pregnancy, different than in training. And so I think I can see where there's those concerns by trainees and early women cardiologists, because I certainly felt it. And I think it wasn't always just being said to me, or it's not something that's directly ever being said. It's just a feeling that you want to be as good as the men around you. You want to be able to be as ambitious and job oriented, and be able to show up in the same way. And so I think ultimately we have worked on changing that culture as we've gotten more women into the lab. And so I think a lot of labs over time, as more women come into to the field, hopefully will evolve and change. But I think there's still, I work with a lot of our techs who are pregnant, don't want to talk about it necessarily with others, and just sort of say, well, what would you do? And sort of helping them connect with radiation and things like that, I think are really important. But it's a cultural change. It's not just one institution. I suspect it's a lot of different places. But it's, I think, best changed through us, and best changed through more of us being present in the field and making it more acceptable to have these accommodations that need to be met. I think we can still be very successful even if your volume is compromised for a year, I think it's really important, obviously, to have women interventionalists and to work together as a team to try to make pregnancies successful for them.
Great advice. Holly, what about you? Coming up through pediatrics versus internal medicine, did you feel like was the advice that you received, did it align with your experience going through that training?
It's interesting, pediatrics in residency is very family friendly, but once you get into cardiology and interventional, I don't think the experience is any different. We still have a paucity of women on the interventional side and the congenital piece as well. I'll say that I think a couple of things. I was very fortunate as a fellow to be with other females in the cath lab. I think that does change things a little bit. I had a mentor and an attending who, as I was thinking about having more children and thinking about adoption for myself, she really encouraged me, which I loved. And looking back, I realized that's a very unique experience compared to other colleagues. But I'll say too that I think that we're at a time now where there's a bit of an era effect, and I'm very grateful to my male colleagues who are taking paternity leave and doing more things in terms of active roles for their children, because I think that changes some of the narrative here. I'm watching our fellows, and the male fellows are taking paternity leave without question, and they'll say things like, "I've got to go to an appointment for my." Child's whatever checkup. And I think that, being women and encouraging that too is really helpful and important for all of us to have a more balanced life. So I'm going to look at it in a positive way. I think the young folks coming behind us are changing some of the culture and the narrative. And it's time for those of us who are in, more leadership positions to embrace that and help them also. I see that there's a question about, how do you figure out if someone's family friendly, but also be taken serious? That's tricky. That's a tricky question. I think asking people, how do you balance your day? What does your day look like? And if people are saying, well, I get here at 5 a.m. and I leave at 9 p.m., that may not be conducive to being at home with 2, 3, 4 children. I think you can ask questions in a way that you can get to know the culture a little bit without saying, I'm not serious. Of course, none of us are saying that, but sometimes that can be interpreted that way. And then lastly, I'll just say, this is a plug that if you are invited to do something in a leadership position, to make a way to do it. Because it is hard to travel, it is hard to do these things, but at the same time, more representation is important and needed. So find a way to do it, and I promise it'll come back to all of us in the community tenfold.
Awesome. No, I totally agree with that. And I do think that there has been some cultural change over the last several years, which I do appreciate our male colleagues that are taking paternity leave, because I completely agree. I feel like that has, I think that that's just the baseline or expectations have changed. Michelle, if you can maybe comment on that. And then also there's a comment in the chat about knowing or how to know if the hospital is family friendly and simultaneously not being taken as someone who isn't sort of dedicated to the field. Maybe you can comment on both of those.
So, since I've already dated myself, I'll just roll with this. But I'm a little bit of the sandwich generation of interventional cardiology females. So those that trained me were very much the old guard, where you went to work and you just pretended like you didn't have any kids. And if they had something at school, they had something at school, and you just weren't there. And, I think that my generation, as it were, is sort of the beginning of where we said, hang on, wait a second. Why do I need to pretend like I don't have children? I think that I agree with Holly. I love to see this new generation of women who take no BS and who stand up for themselves and who say, you know what, this is my space and I'm entitled to it. I would say for me, the most important aspect is to surround yourself with like-minded people. And, so I think that I have mostly male partners. I have a couple of amazing female partners as well, but my male partners understand and appreciate the importance of family as much as my female partners do. With regard to the question, how do you tell if it's family friendly? I think if you talk to the fellows, they get it. And I was sitting in an interview when I interviewed for interventional cardiology, and the interviewer looked at me and he said, "Are you planning on having a bunch of kids?" And I said, "What if I did? What if I did? What if I said, yes, I'm planning on having 20 kids? What would that mean for this program?" And I just turned the question around and his jaw hit the floor. But I said, what if I did? What would that mean for you? Um, and you can very much tell sort of in that reaction how things are going to go. And we don't ask those questions anymore in interviews. We're not supposed to. Um, and honestly, every time I interviewed back in the day when I was in academics and running the program at Henry Ford, when I interviewed a female candidate, I would say, I hope that you've given some thought to your plans for starting a family. I'm not asking you to share those with me, but I would tell you that the only thing you can't get back is time. And so if that's something that is important to you, this is a place where we welcome that and where we want you to go ahead and plan for yourself and make a life. Because honestly, sometimes the people who are hardest on us are other women. And that's crazy. And it probably sounds, but it's true, right? These women who say, well, I did it. I missed all of my kids' activities. I never made it to field day or to violin concerts or to baseball games. And so you should follow in my footsteps. And really, you've got to find people who are like-minded. Nobody ever looks at a person and says, why did you decide to get cancer now? It's really not convenient for the group to have to give you all this leave. Couldn't you have waited another year? Nobody says that, but they're happy to say that about pregnancy. And we don't have time. We don't have the kind of time to wait. And so people need to understand that, and you just need to surround yourself with people who are of a similar mindset. And it's harder to do in training, but it's much easier to do when you get out in the world.
Yeah, I agree with that. It gives you have a little bit more choice in terms of the culture of the program that you select for a job compared to in training where you have to select from what's available. Um, so I think that in order to have enough time to make sure we discuss some of the points that Marcy will bring up in her talk, I think we'll move on to Marcy's talk, which is a pre-recorded talk in light of her clinical work, which is ongoing right now. So I don't know if Kristen is going to go ahead and share that. Thank you. So Marcy Calvin-Press is an interventional cardiologist at UCLA, where she co-directs the Women's Heart program there, and she'll be presenting on building your family as an interventional cardiologist. Thank you.
SCAI webinar on family planning as an interventional cardiologist. My name is Marcella Press, and I'm an interventional cardiology attending at UCLA. Today I will talk a little bit about the challenges facing women who wish to have a family and a career in interventional cardiology. As many of you are aware, though there have been an increased number of women pursuing a career in interventional cardiology, the percentage remains low at 14%, with a less than expected rate of increase over the years. One of the challenges facing women who pursue a career in intervention is family planning. The length of training required, the long hours, the less healthy lifestyle during training can result in delayed pregnancies, with a higher proportion of women getting pregnant over the age of 35. Advanced maternal age is associated with infertility and increased use of IVF as well. During pregnancy, there are also concerns regarding radiation exposure and potential for fetal harm. Unfortunately, some of these challenges have resulted in less women having children compared to male counterparts. In fact, only 63% of female cardiologists have children compared to 88% of males. 30% of females interrupt training for family planning, which also places stress on career advancements. A study performed in 2023 surveying 1,056 female physicians during various stages of training and across specialties found that 76% of participants delayed family planning, 37% experienced infertility, and 47% passed up career advancement opportunities. The AMA officially published a statement in 2022 supporting the accommodation of residents and fellows who elect to pursue fertility preservation and infertility treatment, including but not limited to the need to attend medical visits to complete the gamete preservation process and administer medications in a timely, sensitive fashion. Many of the challenges I just described are quite personal for me. As an interventional cardiologist and a mom, I often reflect on my own journey and the road that led to where I am today. I know that the road I've traveled is shared with so many other women, those who have traveled before me and those that will follow. At the age of 36, I had just finished MD-PhD program, medical residency, general fellowship, interventional and vascular fellowships. I was finally ready to begin a career in interventional cardiology, but I was about 10 years behind my childhood dreams of being married and having a family before the age of 30. My journey to find a partner during training was also difficult. I had lack of time for socializing during training, and it made it difficult for me to find my other half. Luckily, I reconnected with my soon-to-be husband about a year before graduation and began my journey of building a family. Unfortunately, we faced difficulty with conception and, like many others, had to complete many cycles of IVF. On our very last cycle, at the age of 38, I was lucky enough to become pregnant. At that time, I had just started my job as an attending interventional cardiologist. I was the only female in the practice and had actually never met another interventional female attending before, let alone one who had been pregnant and did procedures in the lab while being pregnant. I notified my radiation control, and I also did some reading. I learned that with adequate protection, I could continue cathing safely during my pregnancy, and so I chose to do so. I relied on double leading, use of digital radiation badge, and to ensure that I was safe. While trying to build an academic career, learning how to practice intervention, and generate an income, my pregnancy really flew by. Looking back, I don't think I ever took the time to appreciate the pregnancy itself. I worked until 3 days before my due date, and after delivery, I took only 6 weeks for maternity leave, as this was really the longest I could take without impacting my income. 6 weeks was too short for me, and again, the time just flew by. I wasn't able to breastfeed past 6 weeks, but I did revel in the joys of coming home and watching my daughter grow up. She is now 11 years old, and as I reflect on my journey, I realize that I couldn't have done it all alone. I needed the help of my family, and particularly my husband, to pick up the pieces I left behind, one page, for example, for a STEMI in the middle of the night. But today, when I ask my daughter what she wants to be when she grows up, she says, "A doctor just like you." And those words really help soothe the guilty feelings I've felt throughout the years, missing PTA meetings or school events to cover cases in the lab. I realize I just can't do it all, but I do know that pursuing a family as an interventional cardiologist has provided me with the balance I need to be happy. Each stress at work is balanced by the joys of family life, creating a balance for me that I really cherish today. Thank you so much for listening to my journey. I know that it is one that many women interventionals share. May we all find balance in life, share our stories, and support each other as we fulfill our dreams on this long road.
All right. That was a very touching personal story. Marcia unfortunately couldn't join us today because she had a complex inpatient case that she needed to take care of. And I think that's kind of what ends up happening with us, not infrequently, is that we'll put patient care first because that's, what we feel it's our calling, is to be physicians and to take care of our patients. And I don't know about you all, but I feel like over the years, my children have understood this. They know that, I'm doing something that's important in helping people. And so, I hear what Marcy was saying, and it of course resonates with me, but I do feel like um, there's always going to be that, nagging guilt maybe that we sometimes have, but I think that in the long run, that children do recognize that what we're doing is something that's important, that's taking, us away at, various all hours. Um, I do want to touch on, there's a question in the chat that I don't know if anybody wants to comment on this scenario of being an interventional cardiology fellow, a little bit further along. So like some, I think a lot of times people may be in their like late 20s, early 30s when they're doing their cardiology fellowship. But what happens if you've like gone back through training to become an interventional cardiologist and you're, maybe a little bit further along and you're trying to become pregnant? I don't know if anybody has had any colleagues in similar situations or any comments about.
I think that in that scenario, it's even more important that you claim your space, and that you don't wait. I also did IVF many, many, many years ago as a fellow, and I distinctly remember taking shots in call rooms and all of the stress. And so I can't emphasize enough that if that is something that is important to you, pursue it. Cardiology is not going anyplace. Your eggs, on the other hand, they're going someplace. And, so you've got to do what is important to you. I think when you're looking at programs in general, programs with a lot of females or with a female program director tend to attract more females, because I think that people feel a little bit more heard and a little bit more understood. But I would say if you're 40 and you're looking at cardiology and you would desire a pregnancy, then you make that pregnancy your priority. And cardiology will be there. It can wait. And, with regard to the presentation, there was really only one thing that I didn't entirely agree with. You can do it all. You absolutely can do it all. You can be an amazing interventional cardiologist and an amazing mother. You just can't do it all at the same time. So when I'm at work, I am the best darn interventional cardiologist I know how to be. And when I'm not at work, I'm the best mom that I know how to be. And my kids understand that although they are absolutely the greatest gift of my life, they're not always my number one priority. And they get that. And, they do understand, and they do come around and they see us and they know how hard we work and they appreciate it.
Yeah.
Awesome. Molly, you've got your hand up. What?
Yeah, I wanted to add to that. I have a lot of people who come up and ask me, the same thing, like, how do you do it? How do you do it all? And you're right, you can do it all, but you have to realize that you do give up little things along the way. Like she was saying, like, you're not going to go to every PTA meeting, maybe. You're not going to be able to go to every swimming practice or dance practice or, things like that you may see other parents doing now or going to. I remember my kid was like, why aren't you coming to the Halloween party in the second grade class? And I was like, because I'm working for you so that you can do X, Y, and Z, and so you do give up things. I mean, in high school, that's when I got divorced, was when my kids were in high school. And I still went to my conferences. And I remember my kids telling me later, they called my house the orphanage. The kids at school called my house the orphanage because they were often there by themselves. But I will tell you now, they're both out of college, and they tell me now that I was there when I needed to be there, right? So you're there at the important events, and they were so proud of me for the things that I had done. And they said that they were sorry for how during high school, I mean, because come on, they're girls. They used it against me all the time. And boy, can they make me feel very, very guilty. But in the end, they they were so proud and they talk about me as being some great person, doing great accomplishments. And that's great. But I think what it did for them is it showed them that they could be strong, independent women themselves. And I think that's it. As long as you love your family, you're there, like she said, you're there when you're there, and you're also giving it all at work when you're at work, then it shows. And in the end, so you can do it all, but you do give up little things along the way.
That is also great advice. I feel like I am learning so much today. Maybe we only have a couple more minutes, and I feel like we could talk about some of these topics for a whole nother hour. We've hardly, I feel like, scratched the surface here. But just since we only have a few more minutes, I would like if each of you could just make just whatever, if there's something that you wanted to mention that you haven't had a chance to mention, or any kind of closing remarks. So maybe we'll start with Holly.
Yeah, I'll say, we talked a lot today about pregnancy and family planning, and I'll just say that pregnancy is a finite time. Your children are alive for the rest of your life. So, whenever somebody says it's not a good time, it's not a good time when they're 5 and they throw up in the middle of the night. It's not a good time when they're 11 and have an issue at school. The reason that I mention that is if it's something that you really want to be a parent and an interventional cardiologist, you have to learn how to intertwine those things and using people that are role models around you. They don't even have to be at your institution. But, SCAI is a great way to do that, meeting other women who have figured it out. And I'll say that the 10 months is really not the thing you should be occupied with. It's about becoming a mom who's also an interventionist and an interventionist who's also a mom. And there are great ways to do that with all of us. We're happy to share our mistakes so that you can make new ones.
Jen, any last words here?
Yeah, I think Molly's words really resonate with me. I feel like I have sort of perpetual guilt, whether it be mom guilt, I'm not doing enough at home, I'm not doing enough for my job. And there's never a point at which you don't feel guilt. But I think as I grow through my career, I'm realizing, when I have to miss things for my kids, I can still raise really incredible kids. I can still be a good mom and be there for them and do the things I'm passionate about throughout my career. And I think I'm praying and hoping that they see that they see a mom that's trying to do both, and it really creates kids that are maybe a little bit more independent and can really appreciate those struggles that happened sort of early on in their childhood.
You're role modeling. All right, Michelle.
So a couple things. Number one, just remember that there are a lot of ways to build your family. And so as physicians, we do tend to struggle with infertility. I have done in vitro. I have lost advanced pregnancies. I've carried pregnancies. I've adopted domestically. I've adopted through foster care. There are a lot of options. And so, try to sort of keep yourself open to those options. Remember, if you do choose parenthood, that it is one giant exercise in adjusting your expectations, because they're not going to ever turn out to be the people that you envision them to be, but they'll be wonderful people nonetheless. And then finally, for our female colleagues who choose not to have children, let's remember that their time and their space is just as important as ours. And that we need to also be respectful of that, because I think sometimes the tendency is, well, you don't have any kids, you don't have any kids, you don't have any kids. And so, we have to be respectful of all of our colleagues, regardless of where they are in their life and what choices that they've made.
Well said. Molly, get the last word.
Okay. Yeah, I want to agree with Holly. Really, there's never a good time to do anything. If there's something that you want to do, you just do it and you will figure it out. And as long as you'll always have that guilt if you have children, I think, in being a mom. Like Jennifer said, it's there, and you just kind of work through it, and knowing that as long as you're doing a good job as a mom, you're there when you're there, and you're at work when you're at work, and you give it all to both ways, they will see it. I promise you. When the kids grow up, they'll be more proud that that was who you were. So I think it's definitely doable, and you just have to take the bull by the horns and do it.
Awesome. Well, we are out of time. I understand that we have had almost 300 viewers of this webinar, which is really inspirational that there are so many people interested in this topic. I think that's fantastic. I think that says a lot about, the interest in the field of interventional cardiology, which is an amazing field. And, I would strongly encourage anyone who is interested in the field, whatever your background or future interest, to consider it, because it is very rewarding, and it's a very exciting and interesting field, and you can really make a big impact on patients' lives. So I am so appreciative of our wonderful panel and our speakers. I just really appreciate everybody's time and being present today. And of course, Kristen Perry and Laura Porter from SCAI, as well as our SCAI-WIN SCAI staff, with Chris Trimmer and Rachel Pham, who are amazing supporters of our committee. And so, yes, thank you so much. So I think we'll actually conclude at this point. We're 3 minutes over, and I want to make sure we don't overtake people's evenings. So.